We got things together. All right. We're Physicians Health Network. All righty. And we're a group of Black physicians that are here to answer your medical questions, basically. So welcome, everybody. We have two guests that are esteemed guests. Number one, we have Dr. Kareem Salam, who is a child and adolescent psychiatrist. And in this time of COVID, there are so many of us that are having psychological issues in Black and Brown communities. I think he is just the key person to be here to answer some of those questions. Secondly, on the second part of our program, we have Dr. Wayne Graves, who is coming in, and he will be answering questions as far as COVID is concerned. He's an infectious disease doctor, and basically he's at the forefront of research. And these are the type of people that we need to answer our questions. They are Black and Brown, just like us, guess what? And they're gonna answer it from a Black physician's perspective. Okay, number one, do not change any aspect of your medical care before you consult your physician. The reason I say that is because I could have diabetes, you could have hypertension, the medical problems that could come about us changing what our doctor states because someone else said something can be devastating. So do not change anything. Alrighty. I want to thank OBHealthy for allowing us to use their platform to bring this to you. Okay. So that's it. Let's get started. You know, there's so much we need to cover. I'm going to look here and see exactly where we are. And we're going to get things going here. All right. Just give me one moment. All righty. You know what I'd like to do? I would like for everybody to introduce themselves. All righty. And we're just going to start with Dr. Atherley because on my screen, he's the first one. All right, Dr. Atherley, say hello.
Good afternoon, everyone. Pleasure to be here as usual. My name is Trevor Atherley. I'm an interventional and general cardiologist. I practice predominantly in the Newark area. And one of my pet aspects of my practice is the teaching aspects. I'm with the clinical teaching faculty of Newark Beth-Israel Medical Center.
All righty. Dr. Court.
Good afternoon.
Dr. James Court, can you change your angle of your computer there just a little bit so that we see your whole face?
Okay.
All righty, great. Thank you.
Good afternoon, this is Dr. James Court. My specialty is internal medicine. I practice in East Orange, New Jersey.
All righty. And Dr. Kareem Salam, am I saying that right?
That is correct.
All righty. He's our guest today, and he's, go ahead, tell us about yourself.
Good afternoon, everyone. My name is Dr. Kareem Latif Salam. I'd like to thank Physicians Health Network for inviting me as a guest. I'm a board-certified adult and child and adolescent psychiatrist, and I'm the medical director of adolescent services in a hospital in the city of brotherly love and sisterly affection known as Philadelphia. So I am tuning in from the South Jersey area, but I'm originally from Brick City, Newark, New Jersey.
Right. All righty. Sounds good. Dr. Patrick Anderson. We have an audio problem with Dr. Patrick.
Can you hear me?
Yeah, we can hear you now. Go ahead.
Okay. My name is Patrick Anderson. I'm a board-certified GYN oncologist, chief of GYN oncology at Newark Beth-Israel Medical Center. I take care of primarily women with reproductive tract cancers. I'm part of the teaching faculty at Newark Beth-Israel Medical Center. Thank you.
All right. Thank you, Dr. Anderson. Dr. James Lee.
Hello, good afternoon. Dr. James Lee Jr., board-certified orthopedic surgeon practicing in Essex County, specializing in community orthopedics and sports medicine, clinical faculty at Rutgers University.
All right. Thank you. Dr. Kendall Sprott.
My name is Kendall Sprott. I'm a pediatrician with a background in critical care and general pediatrics.
All righty. Thank you. I think the brother's being modest. Dr. Dwayne Fredericks. Doctor, you are mute.
It looks like you froze.
Yeah. All righty, we will come back. We will come back to him. Dr. Jordan Garrison.
Good afternoon. My name is Jordan Garrison. I'm a board certified general surgeon, as well as bariatric surgeon and vascular surgeon. Presently, my practice field is in disorders of the venous system and also in bariatric and weight loss surgery.
All righty. And Dr. Nelson Aluya.
Yeah, good afternoon, everybody. It's a pleasure to be here once again. Nelson Aluya, Nigerian born, American, trained in medicine pediatrics. I call myself a medical advocate, special interest in diabetes and sickle cell. And I go around the world talking about health and health-related issues. I personally currently work at Newark Beth Israel. I'm also a clinical assistant professor at Newark at Rutgers University, New Jersey Medical School. Thank you.
All righty. So when Dr. Fredericks come back on, I will introduce him or allow him to introduce himself. We have several questions that are coming in at this particular point. Let's get started with orthopedics. So how about that? Because we'll do that. At some point, this is what the question says, at some point I will need a knee operation as it's getting to be bone on bone. However, I am holding out by using creams and injections. By waiting, am I doing any damage to my other knee or my hips? Is the knee operation dangerous? Dr. Lee, help us out.
Good question. So arthritis is a condition, as you stated, it's bone on bone, it becomes very painful. And there's numerous treatments that you can use for this. Creams, injections, medication are very helpful. When the joint becomes severely worn, it becomes painful and difficult to walk around. The other side can, in fact, see more weight bearing and can be at risk for further degeneration. The concern for intervening surgically is if your mobility decreases. In other words, if you could walk 2 or 3 blocks and suddenly now you can barely walk to the car or you can't get up and down stairs, those are reasons for concerns and would warrant a surgical evaluation. To answer your question about is surgery dangerous? Well, it is. And I think if I have a discussion with a patient regarding knee replacement, we talk about the risks and the benefits. If the benefits of the surgery outweigh the risks, meaning better pain control, better mobility, better quality of life, versus the medical risks of going through the anesthesia, dealing with the chance of infection, there is a risk of blood loss, then it is something to consider. If you're somebody who has maybe had 3 heart attacks or has really bad kidney disease or has had a stroke, you really have to think about the medical risk involved and see if it is the right operation. So essentially what I would suggest is have a shared decision between you and your physicians, meaning your medical doctor and your surgeon, as to whether this is the best option for you.
All righty, that sounds good. That sounds good. Excellent. Anybody else want to chime in on that, or we'll go to the next question? All right, Dr. Salam, let's get to some psychiatric questions here. And there's some basic stuff. With the time of COVID, I mean, so many things are happening to the Black and brown communities. And the fact that we have to be sheltered in and the fact that our communities may not have the sprawling house that you can, set dad over here and the children in their play area and all of that. We may be in a cramped apartment with grandma and grandpa and now all of this happening. Tell us what we need to do as far as these times to stay sane, number one. And then I'd like you to get into a little bit of depression, maybe how we as people can handle depression and anxiety. And let's just get started with that.
Sure. Excellent questions. Well, listen, COVID is affecting everyone. As we all know, it's not affecting every community equally. Moreover, COVID is novel. It's the novel coronavirus, so it's a new experience. This is a once-in-a-century event, and there's so many differences as it applies to COVID. So, for example, we have to be together, but yet we have to be physically distant. We're not really used to that, and it's very uncomfortable, especially if you're from a culture that's used to engaging in face-to-face contact and with tactile stimulation. Moreover, COVID is having not only mental health impacts, it's having economic impacts. And I think what's causing a tremendous amount of anxiety is the uncertainty associated with COVID. Finally, because our community is profoundly impacted by this scourge, and there's this aspect of physical distancing, we have folks who are losing their lives and they're not communicating with their loved ones face to face and in person. And finally, this is a situation where folks can't even say goodbye at a funeral for fear that it could become a super spreader event. So COVID is awash in uncertainty. It has mental health effects, economic effects, physical effects. And because of healthcare disparities in this country, it has wrought total and utter havoc on the African-American community. Now, in terms of depression, if you have, well, depression, let's think of depression in a number of ways. So you have your standard depression that more commonly presents in adults as sadness in the blues. And then you have depression as it presents more commonly in children and adolescents as anger and irritability. And so the other thing about depression and mental health issues as it applies to our community is stigma. So folks feel that mental health issues render you weak or vulnerable. And folks are quick to pass judgment in terms of someone seeking mental health care. My colleagues on this Zoom webinar may not experience that as frequently. Their patients, you know, if someone's knee is in pain, they'll go see Dr. Lee. If someone's struggling with hypertension, they'll see one of our esteemed internists. No one wants to admit openly that they want to see a psychiatrist or a mental health professional. There are treatments available for conditions like depression. There are treatments available for conditions like anxiety, and folks just have to have the courage and the support to seek these treatments. And finally, to address the issue of stigma, I founded a company called Global Health Psychiatry, myself and 9 other African-American psychiatrists. And the mission of our company is to attack stigma as it applies to mental health diagnoses and treatments in the African-American community. And we do that by publishing literature to uplift and educate the community, and also through community action. And so we've had tremendous success with those efforts. And finally, I know I said finally already, just some more practical things. If you're living in cramped quarters, one piece of advice I have is, most folks have cable television. Give the television a rest sometimes, because sadly enough, there's often negative information being broadcast from television. Take advantage of spending time with your loved ones while at the same time taking personal time. So if you need to leave that cramped space to go for a walk or to run an errand, that's very important. Of course, you want to wear your mask. You want to remain physically distant. But we need, human beings, we need social interaction, and we also need privacy or time alone. And so those things are very important.
Can I?
Well, there's someone else wanted to say something.
Yes, I wanted to perhaps indulge a little bit with Dr. Salam and benefit from his expertise. Now, I'm a cardiologist, of course, and there have been many attempts at linking various psychiatric illnesses to heart disease. One thing we observed is that during the height of the pandemic in these local areas, that there were a lot of undiagnosed heart attacks, myocardial infarctions, for a variety of reasons. I'm not sure if they were occurring at a higher incidence, or if it was that people were afraid to come into the hospital, and their fear, maybe to the psychiatric aspects of it, prevented them from coming in and seeking help appropriately. So we did have an increased incidence later on diagnosed. Now, would you suggest that during these times that people are afraid not only of being labeled as attending psychiatrists, but even of coming out and mingling, coming into hospitals for treatment which may be needed for very serious diseases? Has that been happening among your patients who are psychiatrically impaired?
Well, just to give you a sense of what I do, I work on a locked acute inpatient unit for adolescents. So I'm seeing kids who are in crisis. And interestingly enough, once, I would say after 3 to 5 months of COVID, and we realized this was not going away and we had to pivot towards how do we live with this, my unit reached steady state. So as folks were being discharged, those beds were filling. And in terms of mental health care on a locked acute inpatient unit, it's difficult to hide from that because you're not thriving in the community if you have to come see me. Or things have reached a point where you've been committed involuntarily. So in terms of on the inpatient side, that has, folks have come to that level of care. In terms of community-based care, one advantage of psychiatry as opposed to something like critical care is their telehealth options, their remote options. And so once that infrastructure was up and running, there were more folks taking advantage of those opportunities. But I have to agree with you. Much earlier in the pandemic, I would say during the first 3 to 4 months, there was tremendous fear of setting foot in a hospital. And again, you know, folks felt that their lives were imperiled if they come into the hospital. And then you have to weigh that with the medical conditions they have that bring them to the hospital in the first place. So from my perch on an acute inpatient unit, I have not seen it so much. Also, remember, folks are dealing with such uncertainty and such anxiety, and they're in close proximity with one another. That could be a source of stress. For example, there have been increases in intimate partner violence, domestic violence. All of a sudden, you had a precipitous drop in folks filing reports of suspected child abuse, many of which are filed in schools. So kids are not in schools, these reports evaporate. Has child maltreatment been cured? No, the rates are actually higher. It's just those mechanisms that shone a light on these problems have been dimmed because these kids are not in school.
You know,
Trevor, I'd just like to comment because I'm the CEO of a hospital, and we have a weekly meeting with the Hospital Association and the Commissioner of Health. The issue that you spoke about is real and continues. It is not just something that was prevalent early when people were afraid. And there is a question, and on the call was the CEO at Newark Beth Israel. He said that the numbers of folks coming to the emergency room and to the hospital have not yet come back. And the Hospital Association did a survey that says that a large number of individuals, especially the elderly, are afraid to come to the hospital. And so they're seeing a lot more incidences of late disease, like problems with heart attacks, as well as gallbladder infections, as well as gangrene that are occurring because people are still afraid to come to the hospital. And I'm not sure how you combat that, but people need to be aware that the ability to catch COVID in the hospitals is not probably as great, especially in New Jersey, where the incidence in the community is not as great. And people, if they have an issue, need to consult with their doctors, and the doctors can advise them if it's something that needs to bring them to the hospital. But there's an increase in people visiting urgent centers as opposed to hospital emergency rooms.
right, that's
Omar,
true.
I have a question for Dr. Salam.
Yes, go ahead, Jordan.
Dr. Salam, welcome. Welcome home.
Thank you.
City. Okay.
Glad to be here.
All right. This is more of on a personal nature. I have a young man who was diagnosed with ADHD during high school. He could not tolerate the medicines and intended to manage himself through academics as well as playing basketball. Went to college, played basketball on a high level, did not take medication, graduated with a master's degree. Now is out in the work environment. And what I see is an increasing amount of hyperirritability and the same type of symptoms that I saw when he was initially diagnosed. What is the progression or the treatment for these young adults who have been diagnosed with these ADHD, and now that they're adults and they don't have the discipline or the medications? What is the pathway for treatment for these type of individuals or young people?
Well, thank you for that question, Dr. Garrison.
Yeah, excellent.
In terms of
Omar.
treating young adults, the first thing you have to respect is their autonomy. And so treatment can't be imposed on them. So you really have to invest in buy-in and getting buy-in from them. Now, in terms of treating adult ADHD, there's stimulant medications, but then there are also non-stimulant options like Strattera. That's the one that, comes to mind. There are others like Capve, Intuniv, Clonidine, 10X. The most important thing, though, is really supporting them in their need for treatment, actually perhaps volunteering to accompany them to an initial appointment, and just being there and being available for them. When they're younger, for lack of a better term, the younger the child is, the less of a negotiation there should be, and you could, kind of, for lack of a better term, impose your will on them. But as they're older and older, there's more and more of a negotiation. And when they're an adult, they can reject treatment. So the other thing too is you want to have someone with a master's degree, they have they've crossed the threshold of problem solving ability, and they could really understand the negative impacts of underperforming at work. And so you could talk to them about the proactivity of seeking treatment before problems arise. And so let's shift back to younger folks, especially in our community. And by the way, Global Health Psychiatry, our second book is entitled How Omari Learned to Love School Again, a story about ADHD. And it's about an African-American family and how they rallied around their youngster to support them through ADHD treatment. And there's a parent guide embedded therein. But in our community, there's such stigma, especially with ADHD. And I'm not putting that boy on medication. And sadly enough, untreated ADHD has so many consequences. Earlier experimentation with high-risk behaviors, substances, sexual activity, and all the consequences, unintended pregnancies, higher rates of sexually transmitted infections, earlier rates of earlier interactions with the law, school failure. And so the parent's worst fear actually comes true when this clinical problem is not addressed. So again, the best advice I could offer in terms of an adult: support, buy-in, and consider non-stimulant options like Clonidine, Capve, Guanfacine, 10X, Intuniv, Strattera, and then have a conversation about the consequences that untreated adult ADHD could have in various spheres of their life, professionally, socially, and the like. And let's avoid these problems by getting help first.
Omar, I'm just going to add that one of the things that we said we would do is to sort of help explain and talk in terms that people understand. ADHD is attention deficit hyperactivity disorder. Right. Disorder means that it's interfering with the individual's ability to be successful. If you're a child, maybe in school, if you're an adult, with everything. And different people have different aspects of it. Some have issues of more of the hyperactivity where they can't keep still. Others have issues with focus. But the bottom line is that a lot of the kids that have ADHD, it carries on into adulthood. And if indeed this individual is having trouble with work, even though they've been very successful, I've had some medical students when I was the chair of pediatrics that were diagnosed at that time. And again, the mother had not wanted her to have any kind of medication, but they have to sort of work extremely hard to sort of overcome. And the fact is that she went on medication and she did very, very well. So even though he might not have wanted to take medication early, if he's finding that it's interfering with his ability to be successful in his job, he should really talk with someone about the possibility of medications that might not be as carry a stigma as some of the others might.
Dr. Salam?
Yes.
Dr. Court.
Yes, sir.
Dr. Court.
Okay, Dr. Salam, thanks for being on our panel.
Glad
I'm
to
an
be here.
internist in East Orange, and I'm frequently faced with patients who tell me, oh, I have anxiety. And I'm sure many of our colleagues are faced with the same thing. I don't know if this is a diagnosis that's being overused. Can you help us, please, in terms of what to look for and how would you define anxiety?
Sure. So anxiety is excessive worrying. But beyond that, as Dr. Sprott mentioned, it interferes with your ability to function. Anxiety disorders are among the most common psychiatric disorders. And so anxiety you could have a chronic, that means it's constantly there, baseline level of anxiety that really never subsides, never goes away. And so that could be the presentation of generalized anxiety disorder. And then you could have episodes of anxiety, episodes like a television show, right? Like an episode of a television show. It has a beginning, it has an end, it goes off, a week elapses, and then it comes back. So that's the more common presentation of panic disorder. And so panic disorder is a very specific thing. It could be associated with discrete attacks of anxiety that last usually on the order of minutes, 15 minutes to a half hour. And it could be associated with sweating, racing heart, sweaty palms, just an excessive a fear of, or a sense of impending doom as if something bad is going to happen. And in extreme cases, you are so crippled that you can't leave the home. And you can't leave the home because you're anticipating having another panic attack, and that prevents you from traveling. More specifically, to crowded places, whether it be a shopping mall or grocery store or sporting event or something like that. Also, you could fear having a panic attack when you're in an environment from which escape is difficult. You're on an elevator, you're in a car, you're on a bridge, in a tunnel. And so your treatment might be, well, I just won't go anywhere. And you see what impacts that could have, on someone's life. Anxiety disorders are tremendously common, and they're increasing in youngsters. And I think some of that is linked to technology, because with social media and these various platforms, this is a venue for public humiliation or public validation. So it's obvious, if I'm publicly humiliated, that could be disastrous. But let's say I'm not publicly validated. I'm not getting enough likes, and the impact that has on my self-worth, my value, and my identity. So yes, there's a tremendous amount of anxiety, and anxiety is always heightened by uncertainty. And for many of us, I know I'm not the most seasoned in terms of age on this call, but for many of us, we've never experienced anything like this. And so even for us, it could be very anxiety provoking.
Yeah, Dr. Salam, Pat Anderson, we're kind of beating up on you because, you're a newbie. Help us.
This is my initiation.
That's right.
I'm an alpha, so I can handle it.
Okay, I'm an Anderson, so I can dish it out. Some of the medications that we use to treat some of the sequelae of COVID, for example, steroids, does have some behavioral impact, combined with the old issue of social distancing and the conundrum surrounding that. Help us reconcile, how do we manage folks who have to be on some of these medications, compounded by some of the psychiatric effects of just the anxiety surrounding COVID?
Sure. Well, listen, you want to prioritize clinical issues, okay? And so in terms of a mental health issue, you think of where that trumps all: imminent dangerousness to self, imminent danger to others, or you're psychotic, you're divorced from reality. So in the absence of those, right, because when things reach that level, those problems could do you the most harm most quickly. So if you're not dealing with those three criteria, you set them aside. You focused on the physical health issues, you know, that could do you more harm more quickly, particularly in a setting of COVID. And so if you have someone on a course of steroids, I don't know if they're parentally administered in the hospital, IVs, the one that comes to my mind is IV Solumedrol, or you have PO steroids like a trial of prednisone, you know, and it could mimic mania, right? It could mimic mania where you have an elevated mood, an expansive mood. It could be associated with an inflated feeling of who you are. I'm great. I'm the best at something, you know. So it's useful if you could recruit family members to kind of support that person and keep an eye on them. But I would say really address the medical issues the way you would otherwise, pulling in support people, especially if you don't have acute mental health issues that could really do the person harm, if that makes sense. Also, you could recruit the support of some of your med psych colleagues if they are available.
Yeah, excellent.
Right.
Excellent.
So, this is Dr. Aluya.
Right.
Thank you very much, Dr. Salam, for coming in and
Yes, sir.
for taking the
Delighted
time
to be here.
Yes. So, I mean, now we're talking about the COVID and anxiety and all that. And one of the things I see in the office as well, especially now with the, you know, loss of income, loss of job and everything else, there's a whole mixture, because in psychiatry, it takes an expert like you to decipher which is which. And one of the things that I often try to tell some of my patients is sometimes it's just, you know, an adjustment disorder.
Mm-hmm.
And how do you begin to separate an adjustment disorder from a pure straight up anxiety, or just, you know, generalized anxiety disorder? And I'm sure there are, you know, medications and techniques to approach, you know, each and every one of this.
Sure. So an adjustment disorder really involves a significant life event, something that doesn't happen every day. So, for example, let's say someone became extraordinarily depressed or anxious to the point where it interfered with their ability to function, let's say within a month of onset of COVID, okay? And so they've had to adjust to this devastating event, right? And they didn't really have a psychiatric history that predated that, but now you want to look at the time course, okay? So, you know, after a while, and you would hope that folks with medical training arrived at this conclusion sooner versus later, but until we have a reliable vaccine that's widely available, there is life with COVID, and how do we go about that? And so if you don't make that pivot and your symptom, whether it be depression or anxiety, is interfering with your ability to function over time, months out, then you have to consider, has this become a depressive episode? Okay, is this now an unspecified anxiety disorder? That kind of thing. And again, children are largely measured by school. School's the work of children. For adults who are fortunate enough in this environment to be employed, they're typically measured by that, right? And so if you're not doing well in that environment, then that suggests that you probably need some help. Or even in the social environment, if, for lack of a better term, you've become so irritable and possibly toxic that those who love you are trying to distance themselves from you, then perhaps there's an issue that ought to be addressed.
Right. You know, I want to break right here. And what I want to do is answer some general questions, because we have quite a few general questions coming in. And then what we'll do is we'll try to go back to you, Dr. Salam, and maybe answer, the panel can, and hopefully some questions come in from the audience as well.
That's fine.
The questions are excellent. Let's go to something. There's one on glaucoma. And I have been diagnosed with glaucoma at the age of 68. Is blindness inevitable? And if so, how many years? I have had laser surgery on both eyes and take drops takes drops every day. Can someone help us out with a little these eye problems? Dr. Court, do you see? I know we don't have an ophthalmologist on the panel, but can you help us out with this a little bit?
A little bit. What glaucoma is an increase in the pressure in the eyes. It's usually treated by ophthalmologists, and initially it's treated with drops. There's another type of glaucoma that requires surgery. I'm not sure, or I don't remember which one, if that's acute angle closure glaucoma or not. But generally, if it's not treated, it can, of course, lead to blindness. The time frame, I'm not too sure as to how long. Of course, it depends on if the patient is compliant with their medication, because I'm sure drops will work, but you have to take your medication in terms of how we can educate you in terms of how long it might, or when it could happen.
Right. Thank you. Anyone else want to chime in on that? All righty. I know we need an ophthalmologist to get details as far as that's concerned. The next question, Dr. Aluya, this is directed towards you. I saw a recent 60-minute piece on the possibility of cure for sickle cell anemia. It says here, gene therapy cures sickle cell anemia, 60 minutes. Hopefully you can hear me, Dr. Aluya. All right. Not really. Not as good as before. Can you liven it up a little bit?
Yeah, I know. I mean, yes, sickle cell. Sickle cell is one disease that has plagued us, people of African descent, for so long. Can you hear me?
Can you louden it up a little bit?
Okay, let me see. All right, I'm trying to. So can you hear me better now?
A little better now, yes, go ahead.
Okay. All right.
Closer to the mic.
Right. So there's so much, unfortunately, sickle cell is one disease that hasn't had that much success ever since it was first diagnosed in 1839 or something in a Guyanese young man who came from Guyana to study medicine, dentistry, actually here in the United States. And it's a disease that continues to plague those of African descent, and not just of us. As a matter of fact, we do have sickle cell, in among the Hispanics. It's 1 in 32, live birth, 1 in 500 in African Americans. We have sickle cell also that happen in the Arab continent as well. But like I said again, it's one disease that has not had that much interest in research and in treatment. And that's probably because for a lot of reasons, economic, social, just the impactful interest on it. Nevertheless, we have had medications to manage the disease as compared to actually curing it. I've had a few people who've talked about cure, and that's in terms of bone marrow, but then the complications itself of bone marrow and when to do the bone marrow is the choice. Ideally, for you to qualify to get a bone marrow transplant as a pediatric child, you must have multiple crises or multiple issues of complications from the disease to the extent that is affecting your life so terribly you need to, because bone marrow itself is not a simple issue. Now, often enough, they tend to say, oh, if you're age, 12 and above, you need to, decide that. But some people have always thought, I've had people who reach out to me like, for a child, should I get a bone marrow for my child and all that. But then one of the biggest issues that tend to happen is with bone marrow, sometimes it tends to affect, the reproductive system, especially for females and for males. And one of the most, I think the very successful one I've had in the state of New Jersey, who's the longest, actually right now cannot have kids. And that's an issue she's having to deal with for the rest of her life. So, and one time she did ask me like, Doc, I wish I had the choice in making the decision about having the bone marrow,
treatment, I probably would not have, because now I want to have kids. Now, in terms of what do you call it, the gene therapy, studies have come up talking about the CRISPs, which where they take some DNA structures, modify it and reintroduce it into the individual. The jury is still out there. We don't know how much, of a success it's out there. They've tried to use that in treating other medical issues and diseases, but predominantly they try to, try it first out in sickle cell patients. So one of the, social, political, and ethical concern, with this is why are they trying it first on sickle cell disease? But then again, that's the jury's out there. We're still working on it. Hopefully, if we get enough of us who get involved in research, we'll come out with concrete facts.
All right, all right. So there's no firm conclusion with that, is what you're saying. All right.
Basically, not yet.
All righty. Anyone else want to chime in on that one? If not, I'll go to the next question. Actually, it deals with anemia as well. This is pretty straightforward, and hopefully we can chime in on it. Can you please explain what anemia is and what's the best course for treatment? All righty. I mean, this crosses a lot of specialties. Can somebody start chiming in on this one, Dr. Sprock or Dr. Court?
Yeah, I can start off. Anemia is a problem with the low hemoglobin, and hemoglobin is really a chemical that's found in red blood cells that helps to carry oxygen, and oxygen is needed by every cell in your body. So if you don't have enough hemoglobin, then you're not getting enough oxygen to the tissue, and you can have lots of different symptoms like becoming fatigued or tired or decreased energy or decreased ability to exercise. If you think about hemoglobin, the normal hemoglobin is around 12 in children. It starts to get higher, 14, more in males than in females. But in general, the hemoglobin is really constant. And if you think about it, the red blood cells that you have a life expectancy of a little over 100 some days or so. So under normal circumstances, you're making about 1% of your blood volume every day. That means that you're losing about 1% of your volume every day. So you can become anemic if there's a problem with the production of red blood cells, or there's a problem with the increased destruction or blood loss. And so if one does a blood test and it shows that your hemoglobin is low, the question for the physicians is the problem with decrease in production or increase in destruction or blood loss? The focus should be to look at whether or not your newly formed red cells, which is about, I said, 1% of your total blood volume, is 1%, or whether or not it's elevated. If it's elevated, it means that you're starting to make new red blood cells a lot faster than normal, which means that you're probably losing blood and you have the ability to make the new red blood cells. If one of the constituents of that hemoglobin is iron, and if you don't have enough iron, then you can't make the hemoglobin. And so with the low hemoglobin, you'll do a reticulocyte count, you see that it's low or normal, and it may indicate that you don't have iron. And one of the treatments for anemia, if you have a low iron as a result, is to administer iron. So I think the issue is to try and figure out what is the reason for your low hemoglobin, and it'll fall into those categories of either decreased production or increased destruction, where the red cells are being destroyed. And there are lots of different reasons why that could be. Sickle cell, the issue is there's increased destruction of the red blood cells because of the configuration of the red blood cells by the sickle hemoglobin. And in that case, the red cells are destroyed maybe instead of 100 and some days, maybe at 30 some days. And so you can understand that if their red blood cells are being destroyed that quickly, you need to be making lots of red cells. And someone with sickle cell will have a very high reticulocyte count, which is a young red blood cell. But even with that increased production, it's not enough to keep up to get them back to a normal level And that's why they call it sickle cell anemia, because despite the fact that they're making lots of red cells, because they're destroying lots of red cells, it's not enough to get you to a normal level.
Excellent, excellent,
Excuse me,
excellent.
Omar. Just to reiterate what Dr. Spratt says, I look at anemia in terms of you're losing blood or you're destroying, making blood cells, something is wrong with your bone marrow. You're either losing it from your GI tract or any one of your other tracts. If you're destroying the blood cells, typically in patients with sickle cell disease and other hemoglobinopathies.
Mhm. All right. Dr. Court, thanks for that, that info, but you were a little, you weren't connected good, and we missed some of what you said. Could you see if we could get a better, can you repeat some of it and see if we can get a better connection?
I was just reiterating what Dr. Spratt said in terms of anemia.
Mm-hmm.
If it means your blood count is low, and there are three
Right.
things that I think about. Either you're not making blood, you're losing blood, or you're destroying blood cells.
Right, right.
And you have
Okay.
to look for all the causes of blood loss.
Mm-hmm.
If the bone marrow is not producing cells, then your blood count will be low. And if the cells are being destroyed, as in sickle cell, you're likely to have a low blood count.
Right, right.
I was just reiterating what he said.
Right.
If I may add to that a little bit, anemia, like it's a big topic, and you can split it into two types. Congenital, meaning happen by issues of where you were born and you became born with it, or you just didn't have enough, or acquired. And acquired in the case of blood loss or diseases and stuff like that. But one of the biggest issues that tend to happen in our community is anemia from chronic disease. Chronic disease like chronic kidney disease, chronic liver disease, even chronic heart disease, because the body produces certain chemicals. I don't want to say that, but one of them is hepcidin, especially with people with chronic kidney disease. Because the kidney has a role, the kidney, the lungs, and even the heart has a role in maintaining how your bone marrow produce, those red blood cells. So those chemicals are produced when you're chronically ill. So it's important when you have those diseases as well to go on to check your doctor and make sure your blood levels are up to par. Because if they're not, it therefore means also that the remaining functioning cells of the brain, the heart, everything else is not getting enough blood supply to stay healthy. So, and that's why it's important that one, you must maintain, whatever control, whatever medical disease that you have, and then see your doctors regularly. And that's why we do blood work. So
Right.
blood all the time.
Right.
So, Dr. Bay, if I may just say something.
Yes, go ahead.
When I grew up under the guise of Dr. Spratt, and he didn't say that in his commentary just now, was that anemia is a window into the wide world. And anemia in of itself is just not a disease. It usually indicates that something else is going on.
Mm-hmm.
And sometimes, to put it into perspective, you can address this based on the age of the individual. So based on someone's age, it could be likely that something else is going on, or likely that something else is going on. And when you put into perspective as to acquired anemia, whether it's related to production, is it a nutritional issue, is it an absorption issue as it relates to the GI tract, or is it a blood loss issue as it relates to something like an abnormal blood vessel coupling, or chronic blood loss from a cancer? And I'm speaking from an oncology perspective. So when I see an individual with anemia, then I question the cause of the anemia, and is it a production issue or a blood loss issue? And if it's a blood loss issue, then you figure out, well, why is it a blood loss issue? Is it a vascular issue as it relates to cancer? And if so, where is it? And then you look at that individual's age, and you talk about maintenance care. And when was the last colonoscopy? When was the last time you saw an internist and got a urinalysis? So you try to use anemia to take you in a direction that could ultimately lead to a diagnosis, and not just to say, well, maybe I should just run out and get some iron, or get B12 shots, or drink chlorophyll, or, or utilize the many sources of iron that's available to us.
One of the considerations of anemia is not merely the etiology or the causation, what causes the anemia, but the effects of the anemia.
Right.
And while the effects of the anemia may cause some generalized symptoms such as fatigue, etc., one may also be aware of the consequences of anemia in worsening established disease. Mm-hmm. An example of that might be in a patient who has congestive heart failure, right, or who has some disease of the blood flow to the heart muscle itself, that the symptoms and the function may be impaired because the blood is weaker. It's not carrying enough oxygen, and therefore it may worsen the actual symptoms of these underlying diseases, or it may worsen other manifestations. So it's important that we find the anemia and correct it, not only for the anemia's sake, but because it also may secondarily worsen patients' weakness of the heart, congestive heart failure, or increase the potential for patients to have chest pains from coronary artery disease or disease of the little arteries on the surface of the heart.
Right. Thank you, Dr. Actually, can somebody talk about colonoscopy? I mean, and stool, and checking your stool. I mean, that's the first thing that most patients think about when they have an anemia, either a female who's vaginally bleeding, or have a heavy menses, or if you're losing blood via the bowel. Can someone address that? And then from there, we're going to we'll move on.
So let me just say, as Patrick indicated, I spent a lot of time talking about anemia as a pediatrician, but one of the issues of anemia in women is there's the belief that heavy menses is associated with anemia. And Patrick, the amount of blood loss in a normal menses is extremely low. It's less than a tablespoon. A lot of what you're getting with the menses is not blood, but actual the tissue that lines the womb or the uterus, which is being lost. Although certain individuals may have excessive blood loss, women due to menses, it's not typical. And so the issue is if you have a low hemoglobin, and you may not have symptoms, and you see that the hemoglobin is low, if indeed you look for that reticulocyte count, which gives you an indication as to what may be going on. If that reticulocyte count is increased, it means that you have everything that's there to make the new blood cells. But if you don't, it means that you've lost blood possibly, or you're destroying it. But if you've lost blood, you're losing iron, and therefore you need to look at where the blood is being lost. And the typical spot to look at is in the stool. And you could lose blood, you call occult blood loss in the stool, which means you can't see the blood, and you don't have, if the blood's been there for a long time, you see tarry stools of this. But if you do a simple a test to look for the presence of blood, it may be an indication that that's where it is. And that may be an indication, if you're older in the age group, that you might have a cancer. And so it may be an indication for you to have a colonoscopy to see whether or not you might have a cancer that might be leading to that blood loss. But you can also look at the urine. You could have microscopic blood loss in the urine. You need to look to see where it is. If the issue is with production, you need to look at, well, where's the blood made? It's made in the bone marrow. You may need to have a bone marrow to see whether or not you may have a bone marrow cancer. Leukemia are things that will interfere with the production of red cells and platelets. And you may have problems with bleeding. That is an indication that you may have something like leukemia, because the marrow has been taken up by the abnormal cells that are making the abnormal white cells. So there are lots of different things that you can do. Understand that in also with something like sickle cell, if you have anemia that's chronic, your red blood cell numbers and your red blood cell volume is going to be decreased. And what happens is and Dr. Atherley can talk about it, your body likes to have a normal blood volume and a normal blood pressure. So you'll have a normal blood volume by an increased amount of plasma. But in order for your tissue to get it, the heart may have to expand to pump a larger volume of blood with each stroke. And so with the sickle cell or someone that has chronic anemia, you'll see that if you do a chest x-ray or you do an ultrasound, they'll have a heart that's larger than normal because they're pumping a larger volume of blood with each stroke to keep the amount of oxygen to the tissue normal. Transfusing in someone like that can be very, very dangerous. And sickle cells, if they have a drop in their hemoglobin to a certain level, you need to be very, very careful about that because they have a normal blood volume, even though their red blood cell mass or volume is low. So it's not something that is typical. Everyone doesn't have the same thing. There could be maybe 30 different reasons that one can become anemic. But you need to go through it in a thoughtful process to find out what's going on.
Right. All righty. I think we've covered that subject, and I think we've covered it thoroughly. What we need to do at this particular point, and I see that Dr. Wayne Graves has joined us, and at this particular point, this is our midpoint. So let me just say a few things as far as the Physicians Health Network is concerned. Note that we will be here every second Saturday at 1 o'clock Eastern time. And we're looking to see that and understand that it takes a village, so if you're viewing this today, then tell someone about it. Tell family members, tell church members, tell your group members, because as African Americans or people of African descent, health education is so important. And we're here to answer your medical questions. All righty. Again, I'm going to say, please do not change any aspect of your medical care until you see your physician, no matter what we say, because we're all different and we all respond differently to medical care. All righty. Again, thank you, OBHealthy, for allowing us to use their platform so that we can bring this to you. All righty, and it's just so wonderful that we have all the docs committed to do this every second Saturday at 1 o'clock. You can tell anybody from anywhere in the world, they can tune in. They just have to go to OBHealthy's website, scroll to the bottom of the page, and at that point you will see Physicians Health Network, the button, click the button, and it will allow you to come on and see all of us here to answer your medical questions. You just type it in, hit send, and we will answer the question. At this particular point, I would like to welcome Dr. Wayne Graves. Dr. Graves, let me see if your mic is up. Can you say hello?
Hi, hello. Can you hear me?
All righty. Excellent. I'd like to introduce Dr. Graves, if I may. And then what we'll do is, our usual, we will go through and introduce the rest of the panel, just in case people came in late and didn't get the introduction at the beginning. All righty, Dr. Graves, he's an infectious disease specialist trained at Vanderbilt. Spent 3 years as a visiting scientist at the Center for Disease Control in Atlanta, Georgia, before moving to Howard University as chief of the infectious disease division there. Then moved to pharmaceutical research, first with Schering-Plough Research Institute, and now with Merck. Dr. Graves is a special interest in COVID-19 because of this disproportionate impact it's had on the Black community. Boy, we're so happy to have you here with us today. We've been talking about COVID, and boy, the thing of it is that this disease, we have so much to know and learn about it, and I'm just eager to hear what you have to say. Before we get to you, though, what I'd like to do is I'd like for each physician to give me a quick introduction of who they are. Dr. Atherley, can we start off, please?
Okay, fair enough. Thank you very much. I'm Trevor Atherley. I'm a general and interventional cardiologist, and I'm a member of the clinical teaching faculty of the Newark Methodist Medical Center.
All righty. Dr. James Court, please.
Dr. James Court, specialty is internal medicine. I practice in East Orange, New Jersey.
All righty. And Dr. Patrick Anderson.
Patrick Anderson, board certified GYN oncologist, chief of gynecologic oncology at Newark Beth Israel Medical Center.
All righty. Dr. Jordan Garrison.
Good afternoon once again. My name is Jordan Garrison. I'm board certified general surgeon and also certified in bariatric surgery and vascular surgery. Presently, my practice is directed towards disorders of veins and vascular diseases. I have offices in Hackensack, New Jersey, as well as Florham Park, New Jersey.
Excellent.
Here.
Dr. James Lee.
Good afternoon, Dr. James Lee Jr., board certified orthopedic surgeon, Essex County mainly, specializing in community orthopedic surgery and sports medicine.
All right. Dr. Kareem Salam, our esteemed guest.
Dr. Kareem Salam here, board certified in child and adolescent psychiatry and adult psychiatry. I'm a clinical assistant professor at Drexel University College of Medicine.
All right, Dr. Dwayne Fredericks. Dwayne, you're still muted.
I'm off mute now. Thank you. I'm Dr. Dwayne Fredericks. I'm a bariatric surgeon. I'm actually specializing now in medical management for obesity, and I practice in South Orange, New Jersey.
All right, excellent. And Dr. Wayne Graves, if you want to say something about yourself, please.
Well, just that I'm specialist in infectious diseases, board certified in internal medicine and infectious diseases. Spent quite a while at Howard, heading that infectious disease division, and now more into research and development. I'm here at Merck right now.
All right, thank you. Dr. Kendall Sprott.
Yeah, I'm Kendall Sprott. I'm a pediatrician. I was the chair of pediatrics at New Jersey Medical School and the dean of clinical affairs. My background is in general pediatrics and critical care pediatrics.
All righty. And Dr. Nelson Aluya, please.
Yeah, Dr. Nelson Aluya, internal medicine and pediatrics, special interest in diabetes and sickle cell, former president of the New Jersey Medical Association, who is the Association of Black Doctors in the state of New Jersey. I am a medical advocate and clinical assistant professor at the New Jersey Medical School, Rutgers University.
All righty. And unfortunately, I forgot to introduce myself at the beginning. I'm Dr. Omar Bey in pulmonary critical care. And I have a subspecialty in nutrition and weight loss. I truly feel that weight loss is the key to health for all people of African descent. All righty. Dr. Wayne Graves, we're going to jump right in with you because we've been waiting for you to come as far as COVID is concerned. You know, the thing of it is that this disease has devastated the Black and brown communities. I mean, here in Newark, when the height of COVID, the amount of patients that were coming to the hospital and the amount of people that were gravely ill was enormous. And even still, we're starting to see a little bit of a bump as the kids are going back to school. Can you just give us some understanding of where we are with COVID-19, you know, in New Jersey or even in the country, and what can we expect going forward? Can you help us out with that?
Right, so maybe I'll start by saying what has changed since the epidemic started in January, thereabouts, and how it's evolved. I think what we've seen is that we know that certainly mostly men are infected, mostly older individuals. We've seen, though, a change in the epidemic more recently where more younger people are infected, and now 60% of the new cases are in those under the age of 50. But we're seeing fewer deaths, and this may reflect the younger age groups that are being affected. We've also recognized that there's a wider range of signs and symptoms than we first thought about. For example, in kids, we are seeing this multi-system inflammatory syndrome, somewhat like Kawasaki's disease that we hadn't expected before. And in fact, there are now a few cases being reported in adults as well. We've learned a lot. We are now recognizing that there are also long-term complications of COVID, and this can be manifested in cognitive problems, you know, cardiac problems, but a lot of CNS problems as well. But, you know, so-called long haulers, as we call them, they complain of things like profound fatigue and dizzy spells, memory loss, other troubling symptoms. We've also recognized that individuals with certain conditions are really at a greater disadvantage. Those with diabetes, for example, those who are obese, even those who are hypertensive, and it's affected, as you know, disproportionately Black and brown communities, as you said. I think what we're seeing now is that in the bigger cities where things were really bad initially, like in New York, because it was so dramatic, people are more willing to follow the public health guidelines for minimizing transmission. Whereas in areas where it wasn't that bad, people think it's a joke and mask wearing is frowned upon or even denigrated. And so with that, we're continuing to see cases across the United States. As you know, we're over, 7 million cases and over 213,000 deaths. And I anticipate that maybe as winter comes and as we're more indoors, we will probably see again a rise in infections. I don't think it will be as bad as it was initially because people have recognized that there are ways to minimize the spread, but I do think we're going to see more cases, and it will be confusing because we're going to be trying to sort this out from influenza. So we've got our work cut out, especially in the United States, unfortunately.
Yeah, yeah. You know, can you address, and I know the other panelists will have questions, can you address this concept of hyperimmunity and how it, you know, comes about? They feel that that's the stimulus to this disease and how it affects our bodies?
Right. So the current thinking, part of the pathophysiology of why COVID is so destructive, we know that the virus attaches to the ACE2 receptors, which are primarily in the respiratory tract, but they're also elsewhere in the body, cardiac and elsewhere. So the problem that seems to happen is that when you're initially infected, there's a gradual process over the first few days where the virus migrates, if you will, from the upper respiratory tract into the lower respiratory tract. Then symptoms develop, things like cough, difficulty breathing. And as this is happening, your immune system is trying to fight off this foreign invader, this virus. And the immune system, what it does in some people is that it works overtime. It becomes overly aggressive, if you will, goes out of control. And so some of the immune system actions and substances, cytokines, particularly IL-6, IL-1, and tumor necrosis factor, seem to play an important role in this overactivity of the immune system and actually can cause destruction of the tissue. So in the lungs, we find that there's all kinds of inflammation going on, and it can be overwhelming to the body. And so this hyperimmune response, if you will, is what we think leads to much of the pulmonary destruction, but it can also can affect other areas like endothelial cells and other tissues. So we get, increased thrombosis. People can have cardiac problems, renal problems, but the primary damage is into the lung. And that's what we think is important. And that's where we've been directing most of our therapies so far, except for the antiviral.
Are there other questions that the panelists have? I have questions, but are there any questions out there?
I have a question.
Yes, Dr. Smith.
Is it Dr. Greaves or Dr. Graves?
They call me both, but mostly they call me Greaves up there.
Okay. So Dr. Greaves, welcome. So glad that you're a guest here today on this critically important issue. Could you discuss some of the neurological consequences of COVID in the case designation of long haulers, and have you observed any psychiatric sequelae as well, or consequences of COVID?
Right. So in terms of the long haulers, if you will, we've seen things like seizures, really, really crazy. I mean, in young people that wouldn't have any predisposing factors or reasons for seizures. We've seen dizziness a lot and paresthesias. Those are some of the common things. There are a few people who will complain of confusion. So the CNS has been an important area of study at the moment. Even cognitive impairment, mild cognitive impairment, which is often intermittent, has been seen in many of these individuals. In addition, though, to the CNS symptoms, there is often a profound fatigue in some of these patients, almost like the things we'll see in post-exertional fatigue, which can last on and be really worrisome because there's no clear explanation of why this exists. I think the most disturbing, though, will still be the CNS problems, as you're alluding to. And I think nowadays, in a person who comes into the hospital or emergency room with confusion, you may think they're on drugs or something, or there's something really sudden going on neurologically, but sometimes you really need to consider doing a COVID test, because you might be surprised that in a number of cases, I don't want to say this is common, but it's something you want to think about, particularly in someone with fever or other symptoms that might suggest COVID, a cough, trouble breathing. Yeah, we have to consider those things, although it's in the long haulers that we're seeing more of the neurological problems as opposed into the acute cases that present with COVID.
Dr. Greaves, Pat Anderson here. Thanks for having you. You truly bring somewhat of a different perspective to this panel. From an epidemiologic perspective, can you comment on why there's such disparity between what we're seeing in the United States and some of the other countries of, say, Africa, West Africa, the Caribbean, so on and so forth?
So there are several things to consider. Let's talk about the Caribbean first, because that's probably the easiest, or a place like New Zealand, which is relatively isolated. So in some countries, they've taken things very, very seriously. And I can speak, for example, about Barbados, since I know most of that. There's a strict quarantine when anyone comes in. And so they've been able to, for the most part, control what happens within their community. That's much easier in a smaller place, a smaller country, and where people adhere to public health guidelines. The same thing for places like Italy, bigger countries like, say, Italy. Terrible at first. Deaths, healthcare workers, and the population, crazy. But they were more willing to adopt and follow the recommended guidelines, unlike much of the United States. The United States is a mixture, of course, because some states are better than others. But that accounts for some of it. The other concern that I have, which we're still looking at from a research standpoint, is the role of vitamin D in all of this. I can come back to that later on and tell you my thoughts on that. But the epidemiology, I think, is largely governed by how much people respond to public health measures, and to some extent, whether or not there's still free flow of individuals from areas that are high prevalence areas into those areas. There are other factors in the United States that color our epidemic, in addition to the fact that many states aren't following the guidelines. But then there are areas where where you live can be important in terms of deciding or determining how much at risk you are. And within the Black community and the Latinx community, of course, underlying health conditions play an important part, as well as structural and systemic inequities and racial problems. So those are some of the major issues that I would suggest that influence the epidemiology of this disease and why it's different in some areas than others.
Dr. Greaves, I have a question for you. My brother was just diagnosed with COVID at 11 p.m. last night. And he's with his wife, his daughter, and 3 grandchildren. The question practically is, a lot of individuals who have COVID are test positive or not symptomatic. He has a sore throat. Do you have any recommendations, and we have folks talk to the doctors, of things that might help those individuals who might have been exposed from getting it? You mentioned vitamin D, and there's some other things like Zithromax and zinc that have been thought to play a role. But do you have any advice to folks who may have been exposed to individuals that might either prevent them from acquiring or getting infected or reduce the symptoms?
So right now, there's nothing officially that we can recommend that we know will prevent infection. But here's what I would do. I'm not presenting this as medical advice to be followed by people who are listening. Talk to your doctor and you decide. But I know even Dr. Fauci takes some things that not proven, but could be helpful. So zinc has a potential role when it's taken very early in terms of presenting perhaps mucosal infection, I'd say. Zinc has been used, as you know, for helping to prevent a common cold. It's not great, but it might reduce the duration of symptoms by a day or a day and a half. But the thought from some early research, not yet corroborated, is that early zinc, for example, zinc lozenges taken frequently for the first day or 2, and not much beyond that because you can build up too much zinc because these lozenges contain a lot of zinc, might potentially minimize the upper respiratory tract area. Now, others have looked at using vitamin C, and vitamin C as a general antioxidant, but hasn't been shown to be specifically useful in preventing COVID. But I wouldn't criticize someone if they take vitamin C. Dr. Fauci is the one who takes it. Similarly for vitamin D, though, I'm much more upbeat about vitamin D because there's a lot of research looking at vitamin D and preventing common cold to some extent, or at least severe complications in respiratory infections. And there's now a small recent randomized controlled study, small numbers, but it suggests that vitamin D may be helpful in COVID-19 situation, and there is research ongoing. So I'm a big believer in vitamin D because there are also studies that show that if you look at the outbreak, for example, in the New Orleans area among Blacks with COVID, we know that the vitamin D level in some of them was lower, and this is true in some other studies as well. And so there's reason to consider there's hope for vitamin D, and we know that in dark-skinned individuals, of course, we don't make as much vitamin D in our skin. And there are several studies that show many people, mostly those of color, have low vitamin D levels. And so vitamin D can be helpful. It's pretty innocuous, you know, take 1,000 to 5,000 units a day. That could be something to consider. So I'd say between vitamin C, vitamin D, probably zinc early on. Another compound that has been shown to be helpful in at least 1 or 2 influenza outbreaks is a compound called N-acetylcysteine, or NAC, which you can buy. And that is not an unreasonable thing as well to add to your toolkit, if you will, if you've been exposed. About vitamin D though, the acute dosing doesn't seem to help as much as if you were on vitamin D before it started. That's what I would say. So here's some suggestions that may or may not work, but I think are not unreasonable.
Excellent.
Can I ask a question about some of the long-term consequences, Wayne? First of all, let me welcome you as a fellow Arizonian. We went to school together in the old days. We're glad to have you on the program. As we become better at treating the acute problem and the early mortality is less, I've been becoming more and more troubled by the long-term consequences. There are a few studies, especially in my field, which have been bothersome. One was the extent to which the heart appeared to be involved. Firstly, in those patients who died of COVID, where more than 50% of these patients did have pathological or examination of the heart at the time of the death or showed involvement. But importantly, in patients who didn't appear to have much by way of symptoms, but who've been subjected to some rather elaborate heart testing, MRIs of the heart, special kind of picture of the heart. And these have shown, even in patients who had very little by way of symptoms, and they've shown much later, an inflammatory process and inflammation going on in these structures. How can we predict and what can we do about these in patients who've had mild episodes, but who still seem to be at danger for a future, if not a COVID attack, but an attack of the tissues, myocarditis or some other inflammatory process continuing in these patients who had what appear to be minimal symptoms?
Right, so what we were thinking is happening is that the immune system continues to be a bit out of control. And so things like myocarditis and, inflammation of the endothelium in general, even in the, CNS is another big area, and the kidney. We think now that what's going to happen is that people who recover from COVID are going to have to be followed up long-term, probably more than a year, to be able to monitor and manage continuing inflammation in different organs. And the heart is of particular concern, as you know, because myocarditis can be quite deadly. You can even be subject to arrhythmias. And the CNS is another important area because people are becoming confused. We're occasionally seeing seizures and cognitive disorders that don't make sense. People think they're fine, but they're not acting fine, as some of their family will tell you. And kidney, there's a lot of kidney failure that's come about from this COVID-19 infection. It's not just pneumonia, death from pneumonia. And of course, you know about thrombotic episodes that can occur. One of my friends, was in the hospital, went on a ventilator, thought she might have died, but got through all of that. Came home 3 hours later, dropped dead. She was on low-dose anticoagulants, but it wasn't enough for her. So I think what this disease is telling us is that we have to stay humble and recognize that we are still learning. And so what I tell you today may be a little bit different tomorrow. And I think we have to be humble enough to recognize this. This is not just some strange virus that destroys the lung. This destroys other tissues. And when you think that inflammation has subsided, it almost seems as though between tumor necrosis factor and IL-6 and IL-1, there's ongoing inflammation. And I think we're going to see more of an approach where it requires long-term monitoring. We're continuing to study the immunological effects of this virus, and there may be more clarity as to why certain tissues are more affected than others. That's about as much as I can say for now, Trevor.
Well, what about?
Hold on, Patrick. Dwayne, Dr. Fredericks, did you have? I know you've been trying to ask a question. Go ahead.
I just want to know, because I deal with weight management, and I want to know your views on the obesity aspect of why is it so rampant among patients who are obese. Does it have to do with the fact that the fat cells are really receptive to the ACE receptors? Are those the reasons why it gets so prevalent with the obese population?
Good question. And I really would like to encourage all of you who see your patients, those who are obese. Obesity is a major risk factor for death if you become infected. It's not so much a risk to become infected, but if you become infected, that's a real problem. And of course, the more obese you are, the worse it is. So the problem with obesity is severalfold. Of course, if you're very obese and you can't move your diaphragms, that's part of a problem. But the bigger concern in COVID-19 is that SARS-CoV-2 infects ACE2 receptors wherever they are, including adipocytes. But in obese individuals, the fat cells, they tend to produce IL-6, period. So obese individuals already have low-grade ongoing inflammation. IL-6 is one of the worst of the cytokines that contributes to the cytokine storm, or that hyperimmune response in COVID-19. So if you got a situation in obese individuals where your baseline is already elevated, along comes this virus and your body goes into overproduction. And so we think that's the kind of genesis or pathophysiology behind the obesity issue.
Could you explain what a cytokine is?
So a cytokine is a molecule, a protein produced in the body by immune cells that can signal to other cells to become reactive, to help fight off an invader, in this case, a virus. And there are many
I have one question.
Yes.
More on the epidemiologic side of things again.
Okay.
And looking at, again, the disparity between what's going on in the United States and some of the other not so developed countries, Caribbean, Africa, and so on. Is there, or could there be, an explanation as to the differential in infectivity and case numbers based on prior vaccination footprint? So for example, we know, for example, that we were taught that if you get BCG after 20 years, you lose the protection. So could that be an explanation that the vaccine footprint or platform that's employed or deployed in some of these other countries that are quote unquote prone to tropical and infectious diseases create a sort of intrinsic protection that could explain the incidence of the virus in those communities?
So that's a very good question. And there's been a small look at a few patients who were infected, looking at their BCG status. I think it was maybe in Kenya, I'm not sure. And there wasn't any clear evidence, but that was just a small study. And I don't remember now, one of the international organizations is planning to look at that in more detail. But here is a possibility. It is not far-fetched in a way, because what BCG does is that it doesn't only protect against TB when you're given it, it revs up your whole immune system. Even though it's a long time ago, our immune cells consist of what we call, T cells, and they have memory. And a memory T cell, even though you may have been vaccinated years and years ago, may still respond when you're exposed to new antigen if it sees that there's something there where it needs to respond. So there is some thought, it's not popular, but that BCG vaccination might be a way to boost immunity to people who might be at risk. At the present time, though, they're not data to be able to support it, but from a theoretical standpoint, it's not unreasonable.
Right. Well, this is Dr. Aluya. Thank you, Dr. Graves. Thank you for coming and such exposition on everything you've talked about. As an individual who had survived for the COVID myself, I went through, some of the acute symptoms of the disease, and I always tell people this: COVID, it's a virus. COVID-19 is a virus. It may be novel, however, it's still a virus, and it has acute, or short-term complications and long-term complications. And again, it's a virus that's writing its own textbook as we go along, and we're going to learn so much from it as time goes on. If it, just completely get cleared out of the system, or if it gets imbibed into one of our immune system one way or the other, including, dendritic cells in the brain or anywhere else. And that's why the long-term, complications that we may continue to look out for. But then in terms of the disease and the pathophysiology itself, I know you talked about, the complements and the surge, the cytokine surge. Now, which is a big story that's been talked about. And the immune system, the virus attaching to H2 receptor, which, as we know, especially those of us of African descent, diabetes is big on us, and you did mention it. And the increase in diabetes in our community is parallel with obesity, as we've all known, over the years. And H receptor is actually upregulated in individuals with diabetes. Now, there's another, theory that's been put out there in terms of bradykinin as an explanation for, the upsurge in the hyper, immune response that's been been talked about with the COVID, not just the cytokine itself. What's your take on that?
Yeah, so I that's good. So there's thinking, at least one group of researchers, it hasn't been corroborated yet, that the pathophysiology is not based on a hyperimmune response as we think, but probably more due to bradykinin and all its complications. So I'd say we need to watch and see if that works out to be true. But here is my take on that, Dr. Lua. Vitamin D works, among other things, by modulating the immune response, which is why I honestly believe it's going to be shown to be very, very useful in this condition. We've looked at drugs experimentally. There's one drug called tocilizumab, which decreases the overreaction, and that has shown some promise in drugs in that class. So it suggests to me that even if the hyperimmune response is not the total answer, it is still part of the issue. Even if bradykinin adds to that, I don't think we're going to be able to say the hyperimmune response and the cytokine storm is still not critical, because when people die, that's what's happening. Yeah. So there may be a bit of both. That's the way I would answer you.
All righty. Oh yes, Dr. Salam, let me just get one question and we'll come back to you. Sure. Somebody asked, since we have an expert here, I want to get some of these questions out. Can you talk a little bit about the concept of herd immunity in COVID?
Yeah. So herd immunity is the concept that if everyone in the population, or a significant enough proportion of the population, is already infected and has developed antibodies, then there's no more transmission of the virus. But there are some concerns about this. Sweden tried this experiment and not really aggressively using the measures that we use to stop transmission, figuring that they'll go for herd immunity. And even after many, many months, the proportion of the population that is actually infected is still very low. Last I checked, it was still like barely 20%. To have herd immunity, scientists and epidemiologists have figured that we need about 50% to 70% of the population to be infected. Can you imagine how long we will have to wait? Even in New York City, which has such a high attack rate, it's not even close to 20%. Can you imagine if we just allow this epidemic to go wild in the United States, waiting for 50% or 75% of the population to be immune? By then, there will be so many people who would have died that you wouldn't know what to do or put them. So the concept has some merit, but in this acute situation, with a virus that can cause death the way it does, I don't think it is an appropriate approach to take for this kind of pandemic.
All righty. Dr. Salam, thank you.
Yes. Dr. Greaves, I don't know if this work has been done yet, but in COVID patients who have neurologic consequences or sequelae, is there any have there been imaging studies done that show any anatomic correlates to their symptoms?
So that is a good question, but I don't know the answer as to whether or not imaging studies have been done to correlate with the symptoms. I know that the dendritic cells are affected, but I don't know if imaging, I haven't followed it closely enough to be able to answer your question.
Okay, I'm gonna chime in with some questions again. Hopefully we can answer these real quick so we can get some other questions done. It states, can multivitamin supply enough? I gather what they're talking about is the zinc and the vitamin C and stuff like that. Would multivitamin, just taking a multivitamin, be enough?
I'd say probably not, because if you want to get your vitamin D up and it's low, if I were talking to anyone in the community, I'd say, look, first check your vitamin D level. It's probably less than 20 or 20. And for this, you want to get it much, much higher. So I don't think the average multivitamin has like 400 or 800 international units of vitamin D. That's not enough. So I would think that it's probably not enough.
Yeah, you're talking about 4,000 to 5,000, right? As far as vitamin D, right? International units.
Certainly 2,000 and up.
Right.
2,000 and up. Yeah,
right.
A recent study that I read is that they're recommending 4,000 and above now.
That's
Correct.
fine.
I understand. Okay, there's another question real quick. I understand that there are two different types of zinc. Which one you recommend taking? I don't know if we can answer this.
So zinc gluconate is the one that you typically will find in, I think it's called zinc E's, or is it Loz-E's? I forget now. But what you can do, here's the thing I'll tell you. If you go to your pharmacy and you look around, you're almost sure to find two different types of zinc lozenges. And I would say, take the one with the higher dose, but remember, we're talking this for just 1 to 2 days.
Okay, the next one, I just want, these are specifically geared towards you so we can get them in. Dr. Graves, if we keep things as it is today in terms of degree of mask wearing, social distancing, daily rates of case reports, and daily deaths, what would you say we can expect in terms of being able to get a hold on the pandemic in this country? I'm asking because I'm concerned that we as a country are not doing enough.
Right. I think if we would do all those things, we would get a hold on it, and we could easily wait until we get a vaccine. If we don't do it, we're going to see pockets where it's going to go out of control. They're going to lock down. It's going to come back down. Then another pocket will occur somewhere else, whether it's Wisconsin or Iowa or wherever. The way we're doing it is not uniform. But I think it's been shown. I mean, look at China and look at other countries. They've done these things. New Zealand, they've brought it down until there's a new cluster. Then you have to go back and do it over again. So if we would do this and do it diligently, I think we know how we can control it. We can't cure it, but we can control it.
Sorry, let me quickly jump in here. Sorry, this is a vaccine. There's a whole complex, globally going around on COVAX. COVAX is, a vaccine that's developed where 171 countries globally signed on, but pushed in by the United Nations to ensure that, countries with low or minimal resources can get the vaccine when they do come on. 2 major countries in the world was not on it until yesterday when China signed on onto the COVAX management. Now, my question is this: there's a whole lot.
Now there's one country, right?
Right, that's one. Well, we know which that is, but there's a whole lot of research that's being done out there. COVID-19 with terms of different cells, including adenovirus and stuff like that, the Mederma virus and the Mederma studies and all that. Now, my question to you is this, and that's the question that we're going to have, and everybody's going to be concerned about it. What would be your ideal vaccine, and what would you take it?
Yeah. So, all right. I hope we're not interrupting Dr. Bay's questions because this will take a little bit of explanation.
Yeah, I know. Just sum up real quickly because I want to get to these questions from people outside.
Right.
Go ahead.
So in summary, you want a vaccine that is safe and that will give you protection. Ideally, you want a 1-dose vaccine and not 2 doses. Many of the vaccines being developed now will require 2 doses. You also know that one vaccine had at least one major issue and was temporarily stopped. In fact, I don't think it's being continued in the United States even right now. So you don't want to rush. You want to have a good, large database of safety on the vaccine. And we aren't sure yet that just because you're producing antibodies that it's going to work. But if it did work, honestly, I'd say I'd be one of the first to get it. I'm a little worried now, though, because there's too much rush in the United States for political reasons, in my opinion, to push things along. So I'm going to wait till there's a lot of data and I'm comfortable.
Right. Let me get some more questions in. Dr. Graves, this is directly, all these questions are directed to you. This is so great. I'm just so impressed that you know, with the audience out there asking these questions. What is a safe amount of caffeine to consume daily? Does it matter? Coffee, tea, or pills? I think you had mentioned something about caffeine in your statement there associated.
I don't think I mentioned caffeine.
Was it that?
I think how much caffeine you drink is probably going to be related to what effect it has on you, whether it causes you to be anxious and can't sleep.
Oh, maybe that's what it was when Dr.
That's
Salam
not
was.
for Trevor.
Okay. All righty. Let's go on. Oh, what it says is, Dr. Graves, can you repeat the things that, hold on, it's skipped on me. Dr. Graves, can you repeat the things that can be taken again? I think they're talking about the vitamins. Just
Yeah, maybe I'll put it into the chat as well. It's vitamin D, vitamin C, NAC, and zinc. I think I'll probably write it into the chat.
Right. Okay. And you know, to tell you the truth, Dr. Graves, with my patients, I add a multivitamin.
That's fine.
Yeah.
Just recognize that you won't be getting enough vitamin D though.
Right. No. All of the ones that you stated,
okay.
Multivitamin added. Add a multivitamin. There's a question, thoughts about the effectiveness of Regeneron.
Right. So Regeneron is a pharmaceutical company, and it makes now what is a polyclonal antibody that we think it looks promising, may be helpful against this virus. So here's the thing. When you get infected, you develop antibodies. Your immune system produces antibodies naturally in response to the infection. What Regeneron is doing is that they're creating artificially the same kinds of antibodies. And that's the hope that they will work. One of the things that we don't fully know yet is that we think that neutralizing antibodies, which is one of several kinds of antibodies that your immune system produces in response to infection, are the antibodies, and this is to the spike protein of the virus. These are the antibodies that are protective. We haven't proven that yet, but that's the thought. So Regeneron is kind of a step ahead, producing these artificial antibodies. And I think Eli Lilly also is having the same kind of production, but that's the theory.
All righty. Back to the physicians.
That's what, by the way, that's what the president took as well, among his huge cocktail of different things that he took. There was a Regeneron drug among many other things.
Right. All right, Doc, do you have any other questions? While we have him here, let's get our questions answered. All right.
Well, monoclonal antibodies. I know how great they're talking about them. They've been used in other, disease conditions. However, they are not for everybody, and they're not exclusively completely safe. So what's your take on that?
So 2 things. Yeah, they have their issues, and they're very, very narrow, as you know. And if there's a mutation that occurs, and the mutation is significant enough, it won't be helpful. The Regeneron antibody compounds, I recall, contains at least 2 different, it's polyclonal, it's not just monoclonal. And that's probably a little bit better in terms of being effective against any variants. But monoclonal antibodies, the other thing to consider is that monoclonal antibodies are very, very expensive. So this is not something that you're going to be able to use, like you use dexamethasone, for example, in people who are really, really ill. So these are niche, these are going to be niche products, in my opinion. Convalescent serum, if it really works, preliminary data suggests that it does, but I think FDA was a little bit premature in releasing this stuff, as many of my colleagues think. But that will be cheaper alternative, but even that has issues. All these antibodies have some concerns, so they're not to be just thought about casually and lightly.
So you're talking about the possibility of significant side effects?
It can be something,
or whether
fortunately rare.
At all?
Fortunately rare, but
okay.
Yeah, but rare.
Okay, all righty.
So,
Yes, sir.
just a question somewhat related to what you just said, but a slight difference. The question is that as many viruses do, they mutate. That means that they change, transform, and it sometimes changes the ability for it to become infectious, may change the way that the disease behaves. The vaccines that have been developed so far, is there any chance that as they are developed, that if the virus mutates, that the vaccines that are developed won't be effective?
So here is the latest that we know. I mean, RNA viruses are kind of unstable in a way, but this virus has remained remarkably stable. And so we think, given how the virus has behaved up until now, unless something fairly dramatic changes, the vaccines that are currently being developed probably are going to be okay. Now, having said that, I do want to tell you that we now know, we weren't sure at first, but we now know that reinfection can occur. There are two well-documented cases, one in the United States and one outside the United States, where individuals who were infected and apparently recovered in that sense that their testing became negative, became positive again. And close research and studies of the RNA in those cases shows that the sequences were different. So there was a mutation in each case. But the mutations don't appear to rise to the level of such significance that the current vaccine approach would be in jeopardy.
But that suggests that the antibodies that the individuals made from the original infection didn't prevent a reinfection.
Right.
Right. Right.
But fortunately, the good thing is that, as I said before, your protection is not only based on antibody, but on your T cells, your memory T cells. So that's the good news about, even if there's not complete protection, maybe the T cells will come in and help do the rest of the job.
I have a question that if I think the patient, they're not sure, not patient, but the person, they're not sure if they've been exposed. What should they go get? Should they get a test for COVID, or should they get a test for the antibodies, whether they've had it?
Good question. I'm glad that one was asked. So there are really three types of tests to think about. And the gold standard is the RNA or the nucleic acid or the PCR test. That's one thing. That is the gold standard. That's the best one. And that takes a couple of days before you get your answer because it requires fairly complicated laboratory procedures. Now, people are using an antigen test. It's cheaper, it's faster. You can get results from some of the tests 15 minutes to a few hours, but it's not as sensitive. So we'll miss some positive cases. And in fact, there are some studies that have shown that if you do a test and you're negative, you're false negative, you repeat the test a day or two later, then about 12.5% more cases are picked up. The other thing to keep in mind is that if you test too early, no matter which test you use, it's not going to be helpful. So it takes a while before you become infected. Typically, we say maybe 5 days, but it can be longer. 2 to 14 days is the work. The third test is the antibody test. The antibody test to me is the least well developed and the least accurate of all the tests. So once upon a time, we were thinking about an immune passport. You get your antibody test, you're sure you've got antibodies, you're fine to go back to work. No such luck. This test is not reliable enough and is not ready for deployment in that capacity. It helps us from an epidemiologic perspective to see what a population is like. And we also know that over time, the antibody test tends to wane. And generally, if you're going to do it, we recommend not doing it before 14 days anyways, because it takes about that time for your antibodies to rise before it's detectable. And it wanes over time, which is the other issue with the whole immunity and antibody stuff. We do know that antibodies wane. And from earlier SARS viruses, like the SARS outbreak in Toronto, that area, 2003, SARS, the initial SARS outbreak, we know that after about 2 years, the antibody had waned for the Middle Eastern respiratory syndrome, which was also caused by another SARS virus. It was about 3 years. And we know that with irregular coronavirus infections that we often get that can cause a common cold, you don't really develop immunity. After a few weeks or so, they're gone, you can become reinfected. So even with a vaccine, you know, there's some concern you may have to be getting the vaccine a couple of times, if not every year, maybe every year or whatever. We don't know yet.
Right, right. There was another question.
The level of antibody that's produced by the individual, even if they have the antibody, do we?
I'm sorry, I didn't get the last part.
Say that again, Dr. Sprout.
I said, even though the antibody test may come back as showing that you were exposed, it doesn't tell you the level of the antibody that was produced by the individual.
No, no, and this is why it's more to be used for epidemiology purposes than anything else. It'll tell you that you were exposed, if it's positive, to the virus, but it doesn't tell you, right, how much longer you're going to have the antibody. It doesn't tell you the strength of the response. We know that individuals who are more ill, more severe, seem to get a more severe response and higher antibody titer, but we're not even sure if that's meaningful because again, the T cells are important, not just the antibody.
Right.
And any thoughts about whether or not the use of steroids might blunt the effect of the antibody response?
I don't know that that's been looked at. That's a good question. I haven't seen anything, but then I haven't looked very hard. But you know, steroids are really not recommended early in the stage of illness because you want your body to mount a response. Steroids are really recommended for moderate or severe illness. And that's where
unless
you
you're the president,
immune
right?
system.
Unless you're the president.
Well, do you recommend that people get the flu shot around this time?
I do.
Yeah.
Right. The flu as well as the pneumonia shot, especially with my patient, pulmonary patients, I recommend it highly.
Yeah, both because
you know, I have some patients that have been concerned though that they, you know, because they're concerned about the COVID vaccine, they're wondering whether they should even take the flu or the pneumonia vaccine, and that's a big question in many of my patients. Whether the powers that be are going to change those vaccines or combinate vaccines such that, you know what I mean, they change things around and don't let the common man know. And it can be, there are a lot of theories out there that are bouncing around.
Well, there's a lot of reason to be concerned about the whole vaccine effort because it's been so politicized. And I'm glad to see that a few of the companies have stood up and said they won't even apply for emergency use authorization until they're satisfied that they've met certain criteria. And then the FDA went ahead and put out some guidelines in spite of what the White House wanted. So I'm a little bit more now sanguine about the vaccine. But I think that for the time being, the vaccine is not going to be ready for a little while. Prime time.
Right.
So in the meantime, I think it's important to get a flu shot, get your pneumococcal vaccine shot if you haven't had one for a while, you know, that kind of thing. Just stay as protected as you can for now.
Yeah. There was another question. It stated, who should be and how often should I be tested for COVID, for COVID?
So that's a good question, and it depends in the context where you are. In colleges, for example, among the players who are sequestered like the NFL and so on, you have to be tested frequently. So testing every day or every other day is not uncommon in some of those settings. But for the average person, there's no reason to go and be tested unless you have been exposed to someone or think you've been exposed to someone or you have symptoms.
Okay, all righty. Any other questions? Go ahead.
Yes.
Go ahead.
Yes. With regards to our community, especially in areas where, you know, we live in, you know, clusters and enclosed environments, one of the earliest concerns, especially at the peak of the COVID pandemic, was the spread and how it was spread. And, you know, some studies were being done on whether you have a GI shedding of the virus and what, you know, what value of strength it was. And if that's still the purpose, what it is. I don't know what your take on it is like.
Yeah, so I'm much, much more concerned about respiratory spread, you know, droplets, but I'm also more concerned about airborne spread than I am about fomites. honestly. So while we can find the virus in the stool, occasionally in the urine, rarely in the blood, those sources don't seem to be important sources for spread. So fecal oral spread doesn't seem to be of real concern. Not to say you shouldn't maintain good hygienic situations in sanitary settings. Maybe it's because of that, but that has not turned out to be the kind of concern that we thought it might have been.
Right.
I think that we haven't paid enough attention to airborne spread, and now reluctantly and lately, the CDC has acknowledged it, and I think WHO is on the brink of it. You know, this business of not telling people stuff because of the fear of pandemonium is really, I think, rubbish. But we know that micron particles that are 5 microns or higher, that's fine. They don't go much more than 6 feet. But those that are smaller, getting up to 1 micron, they can stay in the air for a while and just float around. And so 6 feet doesn't really make a big difference. This is why you still need to wear your mask. You know, you can't just give up. And while it is true that masks protect the non-wearer more than the wearer, masks also protect the wearer. And that's the other bad PR we had initially in this epidemic. Oh, it doesn't help you, but you're helping the other person. And this business of altruism hasn't been bought by a lot of people. And I think that's why there's still a lot of folks, you know, my life is about me, so I don't really care about you. I'm not wearing a mask just for you. But if they understood, and there's studies that show there's protection to you to wear as well. We don't hear enough about it.
The reason why I asked is because, you know, the concerns of if, you know, it can be aerosolized, you know, by, you know, because we've had people who, you know, were quarantined, separate rooms and, you know, differences in the bathroom, but then they share one bathroom. And then all of a sudden, everybody else in the house is getting it. Meanwhile, the individual has been kept in a separate room for all the while and no contact. So the concern is if it will be, if it can be aerosolized.
Yeah, right. And you know, in some of the studies in Wuhan, for example, they were able to find the virus in the air in adjoining rooms and stuff. So your ventilation system is also important. And this is where things like HEPA filters and those come into place. And looking at schools, you know, hospitals, airlines, all those things are important because those are even more important concerns than the bathroom. But the bathroom, you can't underestimate it. Remember, because the virus can live 24 hours on cardboard, and it can live up to 3 days on other surfaces, stainless steel and so on. So I don't want to totally throw it out, but I think in the big scheme of things, fomites are not as important as airborne transmission.
All right, thank you.
Or I should say, drop that transmission.
Yeah, thank you. You know, time flies. Time flies, and we have run out of time. And believe me, this has been one excellent discussion. I would like to thank Dr. Graves. Thank you so much for coming on and clarifying all of our questions. I think the questions were excellent. And Dr. Salam, thank you for coming in. And yes, you both were awesome. What we're going to try and do is we're going to try and have a guest physician each month join us so that we can have a topic maybe discussed for part of our 2 hours that we don't cover as far as the physicians that are regulars here. And I just felt that with COVID and what's happening in this country and what's happening in the Black and brown communities, that it was so important to bring both of you on to get an understanding of how we as a people can deal with COVID. And I truly feel that the more educated that we become about this disease, the more we'll be able to take care of ourselves. And you know, it's devastating to work in a hospital and see how much it affects our people overall. So I just so appreciate you coming on to the show today and bestowing your knowledge to the general community as well as to us, because I learned so much today from both of you. And thank you very much. What I'd like to do is close out at this particular point. Remember, never change any aspect of your medical care until you can consult your physician. Remember that we'll be here every second Saturday at 1 o'clock Eastern time. Tell friends, family, church members, everybody who who would be concerned about themselves and be concerned and want to know more about their medical care. All righty. And the fact that OBHealthy is allowing us to use their platform, thank you very much. They're a weight loss, and we were talking about weight loss. They're a weight loss company that is geared for African Americans and people of color. All right. I think that we're going to end right there. Thank each and every one of the physicians. Thanks, Dr. Graves. Thank Dr. Salim. And until next time, I'm going to say peace to everyone out there. We will see you on the second Saturday of next month. Thank you very much. We're going to end right here. Goodbye, everyone.